I might move on to our next speaker, and we've got Associate Professor Erin Barreto, and she'll be presenting a systematic rollout of beta-lactam therapeutic drug monitoring in a large health system. Associate Professor Barreto is Associate Professor of Medicine and Pharmacy at the Mayo Clinic and is a critical care pharmacist. After finishing her Doctor of Pharmacy, she completed her clinical pharmacy residencies in critical care at Mayo Clinic in Rochester in Minnesota. Since joining, she earned a master's in clinical and translational science from the Mayo Graduate School and completed a 3-year tenure as a Kern Scholar in the Mayo Clinic Center. She has received funding from NIAID, AHRQ, and various foundation and industry sponsors, and has authored more than 100 peer-reviewed manuscripts and book chapters. Definitely recognized as an expert in optimizing the safe and effective use of renally eliminated and nephrotoxic medications. So I'd with pleasure, to introduce Erin to present her talk.
Thank you so much, and thank you to the planning committee and the excellent panelists. I'm learning a lot from all of your talks, so thank you for the opportunity to be here. This is my disclosure. And when I was thinking about this talk, this is how I was feeling. I was thinking about the complexities of implementation and how, it feels sometimes like you're this tiny tugboat pulling this massive ship along to whatever the outcome is of interest. And it can seem insurmountable, and yet tugboats are uniquely qualified to pull these giant ships. And it's because of several things. One, it is their design. They're not built for speed, they're built for function. They're shallow so they can get through the water. They have a lot of power built into them. It's because also of the environment that they are in. They're trying to pull these boats in the harbor where it's not wavy and not out of control. And it's because they have time on their side. They are patient and they just make progress little by little. And there's so much about that that parallels our processes of implementation. And so as we think about that, we need to think about environment and design and patience to try and ensure that implementation is well aligned. And that directly relates to beta-lactam therapeutic drug monitoring implementation or any of these precision dosing strategies. So in the next 20 minutes, I'm going to talk about some of the primary constructs that surround implementation of beta-lactam TDM, and then I'm going to talk about our experience with implementing it at our shop. So as you know, beta-lactam TDM, despite our first speaker's thoughtful insights, hasn't had the best uptake. On this slide, what you're going to see is a series of surveys that have been conducted over the last 10 years or so that look at our overall access to beta-lactam therapeutic drug monitoring. And it's not like VANC and aminoglycosides, which are more than 90% available to most hospitals and centers. Rather, you see that some of the earliest adopters of beta-lactam TDM reported in 2013 that only about 10% of respondents had access to TDM for their clinical use. And as we progress and we look at places like France and Germany, we're starting to see that it's really started to take off. And I had the pleasure of hearing from Dr. Roberts about the redo of the admin ICU study that it sounds like is ongoing or has recently completed. And I think we're going to show that there is a significant increase in beta-lactam TDM in the Europe and Australia and New Zealand population. But the US is behind. So the only survey that has been performed in the US suggested that 8% of respondents had access to beta-lactam TDM. But look at the numbers. There were only over 40 individuals, really representing 40 centers, that were surveyed, which is just a dramatic minority of all of the centers in the US. And it was heavily influenced by kind of academic environments. So realistically, we're talking about single digits, very infrequently is beta-lactam TDM being performed. And one has to wonder, why is that? Well, we conducted a mixed methods study looking at the barriers and facilitators of beta-lactam TDM, because realistically, what most people will tell you is that it's because of the assays. We just don't have the assays. And so we sought to understand that and anything else that might have been contributing to beta-lactam TDM uptake. We performed interviews and surveys with clinicians in critical care and infectious diseases, physicians, pharmacists, advanced practice providers, nurses at Royal Brisbane and Women's in Australia, New Zealand, in University of Florida, and at our center, Mayo Clinic, which each were at various stages of implementation. One was fully implemented, one had been doing it for a while, but was kind of more partially implemented, and ours, which is not implemented at all at the time. And we had 140 people or so who responded to the survey, and then we interviewed 30 of them to get an additional, more granular understanding of their perception of the barriers and facilitators of TDM implementation. What we demonstrated was that there's, typical organizational features that you need to implement any new evidence-based practice, including beta-lactam TDM. You need to have institutional buy-in. You need to have an electronic health record-based infrastructure. You need to have assays. And so those are all true, but they're not unique to beta-lactam TDM. Those are kind of broadly generalizable to any evidence-based intervention that involves therapeutic drug monitoring, whether it be beta-lactam or VORI or other things that were talked about today. But what we found that was interesting and unique about beta-lactam therapeutic drug monitoring is there was this issue with individual internalization. So what do I mean by that? Individual internalization really reflects the work that clinicians do to make sense of a new practice. It's the work they do to determine if they agree with it. They try and rationalize that and then decide, okay, yes, I'm going to go ahead and implement this into my practice. And what we found is the storyline with internalization is very different than if you look at you look at TDM for other more mainstream products like Bank or aminoglycosides. So I'm just going to show you two quotes. This is an example of the skepticism that people have for beta-lactam therapeutic drug monitoring. This is one physician and intensivist that said, I think I would have to have evidence of patient outcome benefit, which I've said is a little difficult to get. I don't know of any multi-center randomized controlled trial showing that. Another one said, isn't it funny how we often justify? We justify TDM for every other drug except the one drug that maybe it probably matters the most, which is beta-lactam, right? When it comes to beta-lactam, suddenly people feel like there just isn't enough evidence to support checking levels and adjusting doses. And we heard this time and time again, despite having, very moderate quality evidence for using vancomycin and aminoglycoside therapeutic drug monitoring, largely just for toxicity. We use it every day without question. And yet for beta-lactam TDM, where we've consistently demonstrated that it can be associated with improved target attainment and some clinical outcomes, depending on which study you read and some of the meta-analyses that were previously published, it does suggest that there is certainly an opportunity to use this to tailor doses. So this individual internalization is really one of the key sticking points when it comes to implementing beta-lactam TDM. So I'll just give you a little overview about our center before I launch into how we approached our program with these theoretical insights in mind. Our center has about 2,000 licensed beds in Rochester. We have other campuses as well. Within our Rochester campus, we have about 200 adult ICU beds across 9 different adult ICUs, which care for about 15,000 patients annually. And this collection of ICU patients is cared for by roughly 60 clinical pharmacists in critical care and related disciplines, including infectious diseases and cardiology. So there's a huge pharmacy team that is in our critical care environment and practices 24/7 to deliver clinical pharmacy services. So from an implementation standpoint, just think about the complexity of doing that at a larger center and how that differs from doing it at a smaller center where you only have 1, 2, or 3 people that you need to get on board. We used our implementation mixed method study to inform how we approached implementation of our TDM. And we had 3 general pillars. First was development of on-site assays. So we have the great good fortune of being able to do this work in our drug lab. And we developed a total concentration assay for cefepime, piperacillin, and meropenem that is performed in-house on an HPLC tandem mass spec and has a turnaround time of roughly up to 36 hours. We perform it on a daily basis, Monday through Friday, and it's batched. So depending on when you collect your sample, you can get the response relatively quickly. We also established a bunch of organizational infrastructure. So this is just an example of our Mayo Clinic antimicrobial therapy quick guide website. This is effectively, for those of you familiar, similar to the Sanford Guide or the Johns Hopkins Antimicrobial Guide. We have a similar one. And so on the website for that, we had a specific dedicated area for our beta-lactam therapeutic drug monitoring resources, as you can see highlighted, which linked out to a web repository of a whole collection of different information, including a pharmacokinetic calculator, which could be used to analyze drug levels that we launched in our patients. We also then put together a collection of materials to try and promote that individual internalization, as we knew that that was a major issue that we had seen in our formative work. So you can see we developed a web-based asynchronous learning module for the multidisciplinary team. This included tracks for pharmacists, for nurses, for laboratory personnel, and for providers. And the pharmacists included a lot more operational considerations, but everybody had clinical insights in theirs. We also had an online compendium of resources that I just showed you. We developed infographics that had key messages about which patients and how to perform the levels. We also developed super users or local champions for all of our different ICUs. So each of the 9 adult ICUs had a super user that formed kind of our core group to launch the effort. And then when we had transitioned from an operational experience to more of a clinical interpretation experience from after the beginning of the program had gone live, we realized that we needed to have more conversations about clinical interpretation that had nuance and were more patient specific. And so we invited international experts to participate in podcasts, which we then recorded and shared with our team that kind of discussed cases and key issues that came up about microbiology or about extremes of weight or changing renal function as an example. We did a little bit of an evaluation of the knowledge and confidence among specifically our critical care and infectious diseases pharmacists after deploying this education. And we asked them how they felt about using beta-lactam therapeutic drug monitoring in our practice. And you can see that the majority of people transitioned from neutral or uncomfortable at baseline to comfortable with using beta-lactam TDM after education. We saw, in general, about a 50 to 80% improvement in our familiarity with operational considerations. That means how many levels, when should they be timed, which patients. We also saw an improvement in the percentage of patients who thought TDM was worthwhile, which certainly would be a counterbalance if it went the wrong direction. So educating people can help them realize the value in doing this service. And the majority of people felt that this approach to education was sufficient for them to be able to implement it. We then launched our therapeutic drug monitoring program in June of last year for the 3 drugs that I mentioned. It was a multidisciplinary effort. We had a core team driven primarily by pharmacists, but inclusive of intensivists and infectious diseases specialists. Our approach was similar to what was kind of suggested in the early talk about implementation. We tried to target high-value patients who might have profound PK/PD variability. And so we looked at first select adult ICU patients who are on ECMO or continuous kidney replacement therapy. These patients are advantageous for another reason, in that once you are cannulated or on circuit, you will often stay on circuit for several days unless you die. And so it is kind of a sick, stable state, which allows for us to have a little bit less dependence on turnaround time. That's not to suggest that these patients are not critically ill or volatile or don't have a very difficult and precarious clinical course, but rather to suggest that we're not looking at rapidly changing renal function or something where we get a level and we can't respond to it. So that's where we decided to start. It's also objective, so it's easy to query those patients as opposed to just telling pharmacists, just check it on whoever you think is PK derangements. We then expanded to looking at patients who had extremes of body weight, and then we brought it out to all of our adult ICUs. This was a 2-level monitoring strategy where we checked both peaks and troughs, and we performed pharmacokinetic monitoring using a time above MIC target of 100%. We didn't feel that a 4 times the MIC target was necessary for our center, and we elected not to develop organism-specific targets for the purposes of simplicity. In empiricism, we targeted a pseudomonal breakpoint, as that's often the worst case scenario that we're working with. And then we targeted a specific pathogen if an organism was identified. In the first 3 months of implementation, we had 41 unique patients that we cared for, and the majority of them were on continuous kidney replacement therapy, but we also had patients on ECMO and extremes of weight. Interestingly, what we showed was that 94% of patients achieved at least our effectiveness target, although we did have a pretty considerable proportion of patients who exceeded our safety thresholds. And it really kind of depends on the drug and the threshold that you choose as to how much, but it was up to 20% of people that exceeded our safety thresholds. Across these two, then, what we showed is about 73% of patients were within target on their initial beta-lactam serum concentration assessment. And about 40% of individuals underwent a dose adjustment in response to that TDM, of which a proportion of them were within target, but maybe we're running it just barely where we wanted. And so we decided to nudge them up, or vice versa, brought them down if they were looking too high. To kind of highlight some cases from our experience that might illustrate the potential value of beta-lactam TDM, I thought I would just share two. This is one example. This is an 18-year-old female who was admitted after aspiration pneumonia and developed septic shock requiring BV ECMO. She has a pertinent past medical history of developmental delay in CP and ended up having frequent aspiration events, and she has a history of seizures. Her weight is 45 kilos, and yet her BMI is 30. She's short in stature. And her creatinine was 0.7 milligram per deciliter on presentation, which I think, if my math is right, is somewhere around 60 or 70 for those of you who use a different unit. For those of you who are interested, she also had a cystatin C concentration, which was 1.1, which is roughly normal, and she was making good urine output. So our standard is to administer beta-lactams over 30 minutes. And so she got cefepime 2 grams over 30 minutes every 8 hours. As you may recall, I said that our target was 100% time above MIC. And based on the pseudomonal breakpoint, we would say that a trough concentration for cefepime in her case should be at least 8 milligrams per deciliter unless we have an organism that we identified. So in her case, what we found was she had MSSA and Pseudomonas aeruginosa, but the MIC for Pseudomonas aeruginosa was a bit lower at 2. But look at these PK data. Her trough was 116 milligrams per liter, which is dramatic, right? And I might have guessed that it might be a little bit high given she was a relatively small woman and short in stature, but her kidney function and her age would lead me to believe that it would not have been this high. So certainly this exposes her to substantial risk for toxicity, particularly given her history of cognitive delay and seizures. So for that reason, we were able to use our pharmacokinetic assessment to narrow her, or to modify and tailor her regimen to 1 gram every 12 hours instead. The other case I thought I would share was this gentleman. This is a 43-year-old gentleman with polymicrobial CAP, complicated by ARDS, also requiring ECMO, and he has a history of structural lung disease and was quite sick, requiring vasopressors. His weight is 60 kilos, BMI of 17, creatinine was 0.8, or again, roughly around 70, and was making good urine. And our house standard for meropenem is to do 500 milligrams every 6 hours over 30 minutes, and so that was what he was started on. In his case, our trough concentration goal would have been at least 2 milligrams per deciliter, or 2 milligrams per liter, unless we identified a specific organism, which we did. He had Pseudomonas and Klebsiella from outside cultures, and then he had a Chromobacter, which we may be able to debate whether it was a meaningful contributor, a meaningful pathogen in his circumstance, but the infectious diseases team wanted to chase it because he had such a profound severity of illness and was deteriorating. And of note, that organism had evolving resistance from 1 milligram per liter as a breakpoint up to 4. When we checked the serum concentration, we found that his serum concentration was 4.9 as a trough, which puts him just barely at our target. And we know that he has to we're doing total concentrations. We know that we're trying to penetrate the lung, and we know that he has evolving resistance. So for all of those reasons, we certainly weren't reassured by that drug concentration, particularly in light of his deteriorated clinical status. So we elected to adjust the dose and push him to 2 grams extended infusion every 8 hours. Our next steps are to expand our patient candidacy to other critically ill patients and launch a pilot in our pediatric and neonatal population. We also are going to deploy some enhanced operational infrastructure, which I appreciated in the AI talk that we got to hear about. Integration with the EHR is so important for clinicians to be able to do this successfully. And this is just a mock-up of the pharmacokinetic calculator that's going to be brought into our EHR. And we're going to automate certain aspects of it so we can pull in the drug, it can pull in the dose, the timing of the level, etc. So getting back to these tugboats, it can feel like it is often a losing battle to pursue implementation, particularly for me at a center like ours, which is very, very large and often a little unwieldy to try and, move. But with the right engineering, the right team, and an understanding of what is necessary to do it, we were able to successfully implement it into the practice. I'd like to thank many people on our team, including our funding partners and my collaborators, and I'll be eager to participate in the question and answer. Thank you.
Thank you so much for your presentation.